or at the end. So I'm an A&E consultant, and I've been a passionate believer in about human facts, and that all stemmed from a case I was involved in a large number of years ago, which really changed my way of working, made me think that, in the past I thought I knew everything as a doctor. I was one of those registrars who probably everyone hated. They're a bit arrogant, to be honest. And I was involved in a case where it changed my way of thinking. So I'm an A&E consultant, but I'm also trained as an intensive care consultant. But anybody knows me knows I have absolutely no concentration or attention span, and therefore I couldn't cope with intensive care as a career long term, and to just work as an A&E consultant. But this is from about 13 years ago, 14 years ago, during the swine flu epidemic. And if everybody remembers the swine flu epidemic, it was just like the COVID epidemic, except it didn't happen. We all expected it to happen. We all planned for it, just people didn't catch it. But this was in the peak of when we're just about to start. And I was an intensive care registrar working on our unit. And I got a call from, I was doing a ward round, and I was seeing a 28-year-old gentleman who I knew a little bit because he was a porter in our hospital, and I recognised him because I used to see him at the park with our daughters on the swings. It wasn't me and him on the swings, our daughters, but I used to recognise him in the park, and I used to know him a little bit. And he'd been admitted with query swine flu. And so we were treating him with all the hoods and the PPE, and it was quite hard to communicate. It turned out from his swabs later on that he didn't have swine flu, and he just had a normal pneumonia. But he was getting quite unwell. He couldn't breathe properly, even with a really high CPAP level. He just wasn't oxygenating and needed to be ventilated. He didn't need to be intubated straight away. He needed to be intubated at some point in the next few hours. If he wasn't intubated that night, he would have died, but we had a few hours to do it. I got his wife in and chatted to her and explained what we needed to do, and said, I'm just going to get on and do it. He had no risk factors at all. I then got a call from A&E about someone completely different, and my involvement in the case stopped. But I would have done exactly the same as what the anaesthetist I called up to do the intubation did. I called her up to say, I need to go down to A&E to review somebody. Please can come do the intubation. It's an easy intubation. There's a really good ITU SHO, no problems expected. She came up. She'd got her, in those days, 15 years ago, you get the nod and the wink that you were about to get a consultant job before the interview. She knew she was about to start as a consultant with us. She was absolutely brilliant as a registrar. She'd got medals in her fellowship at the Royal College of Anaesthetists. And if you ask any anaesthetist, that's the hardest exam ever, and she'd aced it. She'd been absolutely brilliant throughout her training, never had any significant problems at all. So she had so Charlie, there's still people flashing up on my screen. There's people in the lobby still trying to get in. I don't know if we can open it up. Sorry, it just keeps on coming on my screen. So she had been she'd come up to do the intubation, and she had a chat with the team. Didn't expect any problems. When they went to intubate, at first, it's 15 years ago, so they didn't do what we do now routinely, which is have a checklist. They didn't discuss what would happen if there was any problems. They just went on and did the intubation. There was no CO2 monitor because, it just wasn't on the checklist, and she'd forgotten it. It wasn't used that commonly then. It's only when she thought she'd intubated, it was only when the saturation started to fall 100, 98, 97, 96, 95, 94 that she realised there's a problem. She came out and tried to intubate again, but again, the saturations wouldn't come up. It was in this point she was in a can't intubate situation. Doesn't matter. She went to the next step, which is which is put an eye gel or LMA in, and she put it in, but couldn't ventilate. And the sats were now 80, 79, 78 and falling. This is the time we've got, which is a very well-known scenario, can't intubate, can't ventilate scenario. She was examined and vivaed on this very situation about 3 months ago, and she answered the question perfectly about what you do, having all the anatomy and the physiology exactly right. But when it came to the crunch in this time-critical situation, she lost situation awareness. She went back to trying to intubate. The SATs was 65, 60, 55. But she carried on trying to intubate rather than doing front of neck access and trying to put a hole in the neck and putting the tube down. After about half an hour, The patient was intubated. He eventually left ITU and went to a ward, but he wasn't discharged home. He was discharged to a neuro rehab ward because of hypoxic brain injury. 3 weeks later, he died of aspiration pneumonia. This patient died and didn't need to. We got a letter from the family. It isn't the type of letter you'd expect. It's a letter saying thank you. Thank you for getting us an extra 3 weeks of life to say goodbye to our husband, son, dad. But the anaesthetist also knew that things could have been done differently. She spoke to her team and the team weren't supportive. This is how she was left to feel. They just said, it's one of those things. Get on with it. That's life. Dealing with tragedy is absolutely awful in our jobs as healthcare professionals. We're going to face tragedy all the time. I remember a case from about 4 years ago, where I saw a 28-year-old and discharged her. She'd come in with some right iliac fossa pain. It was the third time she'd come in 24 hours, and it was at 3 a.m. She was the consultant, and she'd been a repeat attender. I saw her. I couldn't find anything wrong, but she was very, very sensible with some weird pains. I fudged the reason, in all honesty, for a CT scan. The CT scan was normal, her bloods were normal, and I discharged her. I then went to sleep and I woke up to the 7 words no doctor or anyone healthcare professional wants to hear. Rob, do you remember that patient? She died that day. It went to a coroner's and she died of an undiagnosed Marfan's, and she was not tall. There's nothing to indicate she had Marfan's, and she had an iliac artery aneurysm. It was totally and utterly undiagnosable. It was one of those tragedies which had happened, and there's nothing I could have done. However, the case with the porter and the anaesthetist was different. She knew things could have been done differently. She knew if the systems had made sure that the CO2 monitoring was checked, or they could have run through and everybody would feel happy to speak up, then this patient wouldn't have died. Our patient was the primary victim. She was the secondary victim because she never worked again as a doctor because she couldn't cope with what had happened. Our jobs are hard. They are awfully hard. Things are not easy in the NHS or outside the NHS at the moment. We've got to adopt human factors for our patients, but also for ourselves. We've known this, but we're not changing. Thomas Paine said a long habit of not thinking a thing wrong gives it a superficial appearance of being right. We've had the medical model we've used for the last 200 years, and we've not really changed despite how things are changing so much in healthcare. So when anybody talks about what human factors are, they talk about these tragedies, and they are essentially quite rare. And also you go on a human factors course to think, I'm going to learn about how other people make mistakes. I want to talk about a case which isn't a tragedy, which went really, really well, but shows one of the problems of human factors. It's the case when the patient did really well, but things could have been done better, and they could have been done better if we realise we're human, we're fallible, and we need to adopt different ways of working. This involved a complex case with a gentleman who'd gone. He was an amazing bloke. He'd gone out dancing at a local. It was in his 70s. He'd gone out dancing at a local leisure centre where they had a ballroom dancing room next to a swimming pool. He'd had a cardiac arrest whilst dancing. The lifeguard arrived, did CPR, broke a few ribs. He was on warfarin, but he got a return of spontaneous circulation. When he came to us in A&E, he had a very low blood pressure, but he was alive. He was running in and out of VT, and he's cerebrally perfusing because the CPR and the defibrillation was done so quickly. What I had to do was assess the situation, was manage the complex team, because this whole cardiac arrest team was there, and I had to manage in terms of making sure we were shocking him because he's running in and out of ventricular tachycardia, but also he had a hemothorax. He'd lost a lot of blood and needed to put a chest drain in, and I wanted to get some cross-matched units of blood. Now, at this cardiac arrest, there was a large number of people, and I was trying my best to manage it, and I'd asked for blood. And half an hour later, after I'd asked for blood transfusion, a cardiologist spoke up. Now, something very, very odd about the cardiac arrest. Firstly, there was a cardiologist there, which is quite unique. And apologies if there is any cardiologist there, but the cardiologist was so lovely, I was confusing them for a geriatrician. They were so lovely. I just wasn't used to it. And the cardiologist said, Rob, half an hour ago, I told you the group and save had been mislabeled. The problem was I just did not hear him say that. I just didn't hear him. The question is, why didn't I? He could have done some very simple things such as, Rob, are you ready to receive information? Or if he didn't know my name, he could have said, team leader, are you ready to receive information? But he didn't. He just said, the group and save has been mislabeled. He thought I'd heard, but I hadn't. And so when we ask ourselves, why don't we in medicine do things like saying, team leader, are you ready to receive information? The honest answer is because we're worried about sounding like a knob. It is the knob factors of human factors that we don't admit to, because it does sound a bit knobby. And if he'd said, team leader, are you ready to receive information? I'd have thought, knob. But I'd have also thought, yes, I'm ready. It's important and I'm going to act on it. So let's have a look at the impact of that. What I did ask when I heard the group say mislabeled was I asked for the blood to be cross-matched again. What happened is we got the blood in half an hour later. Well, so what? Well, what actually happened is we got the blood pressure was lower than it should have been for longer than it should have been. The patient went to ITU and was on hemodialysis for about 10 days and then on the ward for another 7 days and then discharged 17 days later with a normal quality of life. So a very good outcome. But if I got the blood in earlier, got the blood pressure up earlier, I could have reduced their time on hemofiltration. I could have reduced their time for ward rehabilitation and I could reduce the amount of community physio needed. I could have improved his outcome and saved the NHS money and also improved all our team working and improved our well-being as well. But that just didn't happen. And that didn't happen because of a lack of human factors. A small example, a small case, but actually one which is really pertinent because it shows how human factors isn't necessarily about the massive big things where people die, but about everyday cases. We know this. But as Albert Einstein said, insanity is doing the same thing over and over again and expecting different results. We need a new way of thinking about how we provide care. Look at a human factors diagnostic lens, where we look at systems, processes, team working and procedures, and put it all together to try and improve those outcomes for our patients. And I'm not saying you don't need facts and knowledge. Absolutely you do. But potentially we need to be learning from other places. Because when I, 3 nights ago on my standard date night, I get my Chinese takeaway. I asked for, and if anybody's from Brighton, Danny's takeaway on Portland Road, I recommend. I asked for sweet and sour pork Hong Kong style 24, egg fried rice 16, and crispy aromatic duck 29. What happens every single time I organise the Chinese takeaway? They repeat it back every single time, and I think, yes, I'm going to get the correct dinner. I don't think, knob, why you're repeating it back. But when I'm at work and I ask our teams to repeat things back, the standard response is, I was listening, don't you know that? Why do you think I wasn't listening? Or think it's an aggressive stance to say, can you repeat it back? We've got to learn from other factors. So Chinese takeaway is a good example. Wetherspoons. We made simple mistakes. That group and save should never have been mislabeled because it's a standard procedure. You don't need to be a genius. You just need to do the same thing over and over again. Wetherspoons have their prompt cards, which just tells you exactly what to do when making a cocktail. And that's why they don't get it wrong. And that's why we need to adopt from that type of place. And I know we always learn from the pilots, but it's not just the pilots we need to learn from. So what is the healthcare issues of human factors? We know impacting our patient safety. 15% of our diagnoses are wrong. Human factors, people forget that human factors are also about how we make diagnosis, not the knowledge of the conditions, but how we get to that answer. It's also about 10% of our treatment is given incorrectly. So even when we know what to do, we treat incorrectly. There's impacts on our staff. We're the secondary victims. We've got litigation costs, but most importantly, there's increased costs for standard care. It's not like we've got so much spare money in the NHS that we can afford to not do human factors. We can't afford not to do it nowadays. The question is, why does errors happen? And there's two models. There's the person model, the system model. The person model blames us as healthcare workers. If we forgot to the group and save correctly, it's our fault. The systems model is there's other factors going on. I'd like to give an example which shows a bit of both. So about 3 years ago, I asked for an X-ray for an elderly lady who'd fallen over. I went to have a look at the X-ray and it looked completely normal. So I told one of our healthcare assistants to go and mobilise the patient. And they were a fantastic healthcare assistant and doing their nursing training. They asked to look at X-ray. I said, of course. They went to have a look at the X-ray and came back to me, and I was really pleased because they felt they were able to challenge and make me feel they'd gone the human factors course, which they had, and they challenged me. I said, Rob, I know you told me this X-ray was completely normal, but it looks pretty broken to me. And I thought, right, I'm going to explain, why they're wrong and what these lines which look, like angulation, why that's normal. And I had a look at the most obvious fractured neck of femur. And thank God that he didn't mobilise the patient, because I'd have made things so much worse. So the person model is my fault. But let's look at why it's happened. What actually happened was the X-ray had not come through from the system. I'd requested it, but something you have to press on Prax hadn't come through, and it was delayed by 20 minutes. So by the time that the HCA went to have a look at the X-ray, it had come through. So the person model is blaming me for not looking at the date, and it was all my fault. The systems model was, why was there a problem with PACS? Why was there a delay? It's not my fault at all. There should be something saying it's not today's X-ray. But actually, it's a combination because of both, because I was at fault, but the system's at fault as well. Professor Reason also looked at this thing called the Swiss cheese error model, where there's lots of different reasons why something can go wrong, and you need all those conditions, all those things to happen, and then an error happen. And then finally, there's this bucket risk model that there's 3 things which can go wrong about yourself. So if you go to work where you're tired, not slept well, you might be prone to making more mistakes. The context of what you're doing. If I'm being asked to review a patient, but I've also got a trauma going on and I've got 30 in a corridor, I'm going to be much more harassed, and I'm not going to be able to be as on top of my game. And then the task about how tricky it is, not just how tricky it is, but how tricky it is for me. So human factors is the solution. You've come to this talk because you think human factors is the solution. And the problem is, we've got a lot of academics who tell those on the shop floor what to do. But actually, it's those on the shop floor who do it day to day who need to answer what we should be doing. I'm joking, saying Professor Catchwell from an Ivory Town posh academic institution. But this is what he said: enhancing clinical performance through an understanding that effects of teamwork and task work and workplace, blah, 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 blah. I don't understand what that means. I can't put that into a clinical context, because there's the policy papers versus reality. And reality is very different. That's not my A&E department, because I don't want to get in trouble with my work. That is an A&E department up and down the country. But how do we make it work in an A&E department? How do we make human factors work in a GP surgery, in a mental health hospital, in an ambulance, on a ward where there's so many things going wrong at the same time? And you could argue, though, we've already changed. We've already transformed, because we've got the WHO surgical checklist. You all go to theatre and there's surgeons doing it, allegedly. There's anaesthetists trying to do it and trying to get the surgeons involved. Haven't we changed? This was published on the 9th of March. So for 8 months, what has happened in England in the last 8 months? And you can see that there was 325 serious instances of never events. Okay, never events are the wrong person being operated on, the wrong site being operated on, the wrong prosthesis being operated on. We are not solving the problem yet. And when you have a look at the WHO surgical checklists for some of these never events, they're all filled in perfectly. So it's not a matter of not doing a checklist solving it. It's about culture, and we've got to get over a cultural problem. I would say this is a better explanation of what human factors is. Despite working in the NHS, which is struggling to survive, learning how best to not muck up at 3 in the morning whilst being tired and stressed, and having a day on Teams trying to work out on how on earth the service will cope with another round of strikes, cutbacks, inability to recruit staff. That is what we're doing. We need to not just say everything is awful, we can't do anything about it, but we need to say things are tough, we know that, but we can try and improve things. And how can we improve things? We're using simple methodology. And Chris will talk about some of the more complex systems. I'm talking about the human side. So human factors are about judgment, decision making, leadership, communication, team working, empathy, compassion. And it's a set of behavioural and cognitive skills over and above technical competence. It's how to behave and how to think at work. I'm never going to try and teach a midwife how to deliver a baby or do, I don't know what but what I am going to do is talk about the behavioural and cognitive skills to how to escalate concerns, that type of thing. Rather than I'm never going to teach people the skills, but the human factors is what goes alongside those skills. And each of us can adopt things. We can't just think, oh, things aren't going to get better. We can make small differences to our individual patients, small differences to the way we work, and together that can make a change. So human factors can make a difference. And it's not interactive because there's over 400 of you, but it'd be interesting to see how many people have been on courses done by pilots. But that's madness, in my opinion, because when they don't fly planes like we run hospitals. If they were, if they don't have a co-pilot, they don't fly. If they don't have all the stewards present, they don't fly. They don't fly with double number of passengers, most of them who refuse to put on their seatbelt and are drunk and aggressive and pissing in the aisles. No, they fly in very standard procedures, only if they've got the right number of staff with the right equipment. And so in some ways, yes, it is like it is like elective surgery, where the takeoff is like the intubation, the flight is like the operation, the land is like the extubation. But actually, healthcare in most settings outside of one-to-one elective cases are much more complicated. So what about more challenging environments? I just put out, if anyone, any thoughts, you won't be able to type it, but anybody could type where they think that is from. The answer is my dreams. That is an A&E I'd love to work in and have never seen before. That's more like it. So how do we make it work in those challenging environments? And the thing is, what we're going to talk about is not complicated at all. It's really the granny school for advanced egg sucking. And if they're only basic, do them with excellence. So what can we do to improve patient care and safety? There's a number of things. We need to do this thing called creating a sterile cockpit. Then there's a specific acute leadership skills, some communication skills. I want to talk a little bit about checklists and prompt cards, decision making, civility skills, and then also about involving patients. Sterile cockpit has been adopted from the pilots. It's about creating a situation in which we notice things which are not obvious. We don't make assumptions. We hear, we basically counteract our normal human tendencies, because for humans, we're not designed to run wards. We're not designed to do operations. We're basically designed to run away from woolly mammoths, eat and procreate and sleep. Anything more complicated than those four things gets difficult. So we need to have systems in place, and that's that sterile cockpit where everybody comes in, says their name. We have standard communication tools. We have silence when we're doing difficult things. I just want to show you why you need to adopt these sterile cockpits. Now, this will work for about 50% of people. I want you to...
Here's a quick test of your powers of perception.
I want you to really concentrate, because I don't think people can concentrate and count the number of files correctly. So please count the number of files. Just count, please. Just really concentrate and count.
There are 2 red files and 2 green files.
Please concentrate.
Count how many times this red file is passed from one person to another in the next 20 seconds. Ready? Start counting. Okay, so how many times did they pass it? If you've got near to 8.
So, if you can, I'm not sure if this is going to work. If you can just type away on the chat, let's see if I can. If you can put on the chat, I'm not sure this works. How many think you've got? Can you just type away if you can? Just some numbers. So we've got between 13, 9, 16. Okay, let me just. Oh, I seem to have lost you. Right. Okay. Being honest, did you all see Danger Mouse? If you didn't see Danger Mouse, just say no. Just type away no. So about half people wouldn't have seen Danger Mouse. Did anybody see Danger Mouse? If you've seen Danger Mouse, just type so I can see that people are still here. It's really hard to do this without any interactions. Just type away if you saw Danger Mouse or didn't see Danger Mouse. I can just... so about half. Some saw it, some didn't. Okay, so for those who didn't, those who did, a lot would have expected it, because you're expecting a human factors talk to be something like this. But I'm just going to...
pretty well. But
This
just
those
how
people...
much were you paying attention? Watch again. You may have spotted that this giant mouse...
So you can see there, Danger Mouse. Now, about half of people who don't know about this don't notice that. And that's because we can only see things we're looking for. We don't notice obvious things. And that's really quite scary for some people because we're not as good as we think we are. We are human. We make mistakes. Just want to do this. This is a key stage. For those who've got kids, this is key stage 1. This is letter recognition. Please count the number of F's you can see and then type it into the answers, the chats, please. So please type the number of F's. It's not difficult. It's not complicated. So I know you can't speak because there's too many people on Teams to make that work. But could you please just type away the number of F's you saw? So most people are saying 3 or 4 or 3. That's great. So the answer is 6, which will shock a lot of you because it's a simple question, even for A&E doctors who are not used to counting beyond E. But there's 6. Most people would have missed the OVs, and OV is obviously spelled OF. Again, showing you that you're human and we make mistakes. So that's why we need to have that sterile cockpit. Last one, please read that. You're mostly reading about Paris you're mostly reading Paris in the spring, but actually it says Paris in the spring. This is why we need that sterile cockpit attitude. Leadership is important. It's about counteracting natural tendencies, about something called the Ringman, the bystander effect, the Ringman effect, the Abilene paradox, people not wanting speaking up and just doing what you're told. Bystander effect is when you just leave someone alone because other people are doing it. And it's really a good example, clinical care, when you say, can somebody get me, can someone do the group and save? Then nobody will do it. The bystander effect, when there's lots of people, nobody gets involved and does it. The Ringman effect is about when there's lots of people in your team, they put less effort in each person. So the team members goes up, the individual effort each person puts in goes down. So you need to manage that. And that's, you can see some people, as I say, if they're too relaxed, need a bit of a Nike enema to work harder. Some people in our teams are too stressed and need to be made to realize that things aren't, to relax, and therefore their performance will be better. So managing those team members is important. The Abilene paradox is when everybody, you go along with a group, even though you don't agree with it. So you must have been in examples where everyone's going, let's go straight to CT scan. Let's not go to theatre, for example, in a trauma, when individually everybody's disagreeing, but everyone's nodding in agreement. So the team is going in one direction, individuals going in the other direction. People need to be allowed to say what they actually think. When you don't make it explicitly comfortable to speak up, people don't speak up.
An experiment is not a public opinion poll. It examines behavior under the pressure of social forces, as the experiment of Solomon Asch reveals.
The experiment you'll be taking part in today involves the perception of lengths of lines. As you can see here, I have a number of cards, and on each card there are several lines. Your task is a very simple one. You're to look at the line on the left and determine which of the 3 lines on the right is equal to it in length. All right, we'll proceed in this order. You'll give your answer.
Only one of the people in the group is a real subject, the 5th person with the white t-shirt. The others are confederates of the experimenter and have been told to give wrong answers on some of the trials. The experiment begins uneventfully as subjects give their judgments.
2, 2, 2, 2, 2, 3, 3, 3, 3.
But on the 3rd trial, something happens.
2, 2, 2, 2, 2.
The subject denies the evidence of his own eyes and yields to group influence.
What?
Asch found subjects went along with the group on 37% of the critical trials.
So you can see there that volunteer was saying the wrong answer, even though he knew it was the right answer, because the group was going along with it. We just got to be really, really careful that we don't go along with the group just because we feel comfortable about it, and we need to be comfortable in speaking out. And so if there's anything to say, is the one thing that we should take away from this is feel comfortable to speak out. It's so important. Communication skills between care professionals is another really important skill that we need to learn. It's not automatically, it's not obvious. And we talk, we have so much training on how we speak to patients about understanding their ideas, concerns, expectations, but very little about how we talk to each other. Absolutely. We need to talk about this Chinese takeaway style of feedback loop, making sure the information is there. SBAR to me is one of the greatest safety tools ever, in terms of how you want to ask a question, because you often get your junior doctors, your nurses, knowing what they want to ask, but you don't understand it. So just put it in an SBAR situation. What's the situation? What's the background, assessment, recommendation? So I'm one of the new F2s. I've just seen a patient with COVID who I think can go home. Background, they're 33, they're fit and well, but they're told by 111 to come to hospital because they're short of breath. On examination, they're completely fine. Stats are 98%, heart rate's 90. I think he's just got COVID, nothing to worry. My recommendation is we send them home and safety net them. Do you agree? And then I always think about SBAR, SBAR. SBAR, situation, background, assessment, and recommendation, and SBAR, the second one is speak, back, and repeat. So you're my new F2, you want me to come and see a patient with COVID who you think can go home. If you put things in an SBAR way of speaking, it makes things so much safer. Then there's how you can escalate concerns. And there's two different ways of doing it. I used to talk about probe, which a lot of people heard, probe, alert, challenge, emergency. But potentially an easier way, which actually Chris is going to speak after, talking about is cuss. I'm concerned about this. I'm uncomfortable. And then finally, this is a safety issue. Stop. So I'm concerned that you're about to discharge this patient because of X, Y, and Z. I'm uncomfortable you're doing this because I think they're sat to 80% and they can't go home. S, this is a safety issue. Can we stop and get a third of opinion, please? So those simple communication tools allow and empower people to speak up. They allow people from HCAs to porters to speak up to the consultants and allow those safety things, because I've made lots of mistakes, but I've been pulled out of them by people who have spoken up to me and challenged me, and that's so important. The next thing is getting rid of medical jargon. We go to medical school to learn a load of Latin that we've never used before, which is just dangerous. Why do we present a patient with hyperkalemia? That some people in this meeting don't know what hyperkalemia means. Why don't we just say high potassium and then say the number, high potassium 6.4? Hyper sounds like hypo. Kalemia sounds like calcemia. Why don't we just get rid of jargon? Jargon can be dangerous and damaging and can affect patient care. So be very careful when using jargon, and especially don't use it to show off or be superior. Your name badges are so important. The Trust ID ones are not that useful because they've got, they've got your picture of you, they've got when you expire, and your name is in tiny writing. You need it big on yellow. Now, I actually don't think this is a very good name badge. It should just be, I think, I know it's a big charity, hello, my name is, but it's pretty obvious if you write your name there, that is your name, either that or you're just really weird. But big in black writing on a yellow background makes a big difference. The next thing we'll talk about is checklists. Now, they can get a bad press, but they do save lives, but they can cause problems. What you don't want to do is people to slavishly follow a checklist, because then they don't change things or notice things. A checklist is there about changing culture, about bringing everyone together. And I brought checklists in for A&E for intubations and sedations about 10 years ago, and they made no difference. It was only when I got rid of them and brought in pump cards, where we didn't need to tick boxes, where we had a laminated sheet with a briefing about what we're going to do about sedation, for example. We just called off the things we needed to check, no tick boxes, and then that transformed the service. It transformed how we intubated. It transformed how we did sedations. And I say, learning from the experts. The Wetherspoons are the best place to learn from your prompt cards, and all our prompt cards have been adopted from the standard Wetherspoon template. That's our emergency induction checklist. That's the standard one, but this is an example of our prompt cards. So this is about how we manage a massive PE, and this was based on the back of a patient where I wanted to thrombolyze them, and that was the really difficult decision, in honesty. But my main concern was I just couldn't remember the doses. So firstly, is this a CTP? Is it safe to go for a scan, or should we just treat them? Could this be something else? Then thrombolyze them, and it tells you what drugs to give, and then it gives you heparin. And I remember thinking this was completely foolproof. And I got a call when I was speaking to our medical students, a question. Yeah, at the back, yeah. What do you do, Rob, if Lucas isn't at work? Which made me realise that maybe I needed to change these checklists, because obviously Lucas is a mechanical chest compressor and not a member of staff. The next thing is about decision making. Now, decision making is incredibly complex, and I'm going to try and cover it in 5 to 6 minutes. But there's things I want to cover, which is cognitive limitations, type 1 and type 2 thinking, biases, fixation errors, and understanding how we make diagnosis. This is the way how we work. Sometimes you can be unconsciously incompetent. Now, that's not necessarily the most junior, because often the most junior people are consciously incompetent. You know what you don't know, which is absolutely fine. Unconsciously incompetent people don't know they don't know it, and they're quite confident. Then you've got the conscious competent, that you know what you know, but you've got to think about, and that's fine. So, for example, if I'm putting a chest strain, I do it all the about not all the time. I do it about once every 6 months. I know what to do, but I've still got to think about it. Consciously incompetent, for example, is I know that someone needs an angiogram, but I don't know how to do it, so I refer it to the cardiologist. Unconsciously competent's got a smiley face there that is a good place to be in, but just be careful because you can get complacent. I remember about, was it 20 years ago, as a SHO in A&E at Worthing, when I was suturing up a gentleman's leg, and the hours were long there, and we did all the suturing because very few EMPs in those days. And I remember suturing up one of those old proper war heroes, suturing up his knee, and did a nice job. And I said, any questions? He goes, is it normal these days to not use local anaesthetic? I couldn't believe he didn't say anything beforehand, but he didn't. And the problem was I was just going into autopilot. I wasn't thinking what I was doing. I was literally just suturing away. Unconsciously incompetent, though, is the most dangerous place to be. And you've got to be careful because you don't know you're that. It's often people who've just completed, say, MRCP Part 1 or MRCS Part 1 ITIS. They're not either IMT 1 or 2s. They've just got a bit of confidence. CST, basic surgical training 1 or 2s, got a bit of confidence and think they know more than they do because they haven't seen enough yet. And again, this is the Dunninger-Kruger effect, where you know a little bit and you think you're really clever, and then you find out actually the more you know, the less you know, and it's only over years and years of experience that you actually do become competent. But remember, confidence is not related to competent, and we didn't need Dunninger-Kruger have made a career out of something which was known years ago. William Shakespeare says, a fool thinks himself to be wise, but a wise man knows himself to be a fool. That is the Dunninger-Kruger effect. Then there's type 1 thinking and type 2 thinking. Type 1 thinking is when you jump to a conclusion. Type 2 thinking is when you're slow and methodical and get there slowly after time. And I just want to, there's times when you need type 1 thinking, and there's times when you need type 2 thinking. I want to show you may not be as good as you think you are at type 1 decision making. I want you to please type away 2 answers, and type away very, very quickly, because we've only got a few minutes time. So it is very hard for interactions online, but please put on the chat function. A bat and a ball costs £1.10. The bat costs £1 more than the ball. How much did each one cost? And a lily pad doubles in size every day. At 48 days, it covered the whole pond. How many days did it take to cover half the pond? I'll give you 30 seconds to answer those 2 questions. Please put both answers in, and please actually, brilliant. So we've got £1.10. Yep. Brilliant. So carry on putting in those answers, please. So I'll give you. So don't look at other people's when you're doing it, but crack on, please. Okay. So I can't see the screen. Oh, someone said they can't see the screen. Sarah Jane Patrick, can you? Is that connect? And anybody else problem seeing my talk? Hopefully everybody else is seeing it. If you hopefully it's okay. So most people have said £1.10. That's because it feels right. The bat and the ball cost £1.10. The bat costs £1 more than the ball. How much each one cost? £1.10. That feels right. But actually, the bat is £1 more than the ball. So £1 minus 10p is 90p. So that cannot be right. So the answer is £1.05 for the bat and 5p for the ball. Because together they're £1.10, and the bat is then £1 more than the ball. Does that make sense? Obviously, I was saying, does that make sense? But you can't respond. So I don't know why I said, does that make sense? But £1, so £1.10, So the £1 and 5p and 5p together makes £1 and 10p, and £1 and 5p minus 5p is £1. So that fits in with the second bit where the bat costs £1 more than the ball. But most type 1 thinking jumps to be £1 and 10p. Same with the lily pad. A lot of people say 24 days because you think half of 48, but actually it doubles every day. So at 47 days, it covered half the pond, and then it doubled to 48 days and covered the whole pond. So human factors is about that we can, you know, you've got these type 1 and type 2 thinkings. Type 1 thinking, you're going to make mistakes. And there's biases which affect our type 1 thinking. And this is just a few of them: confirmation biasing, anchoring biasing, and availability bias. A confirmation bias, a really good clinical example, was that I had a patient who'd, well, not I, but I was doing the, I was involved in the investigation to it. A junior doctor had seen a patient with kidney stones, history of kidney stones, and right groin pain, and a tiny bit of blood in the urine. Everything pointed to kidney stones, but the blood pressure was 90 systolic. And instead of asking for to re-evaluating the diagnosis, it didn't confirm what they thought. So they looked for what they thought it was, and so they again asked for repeated blood pressure, and it was 100 systolics, and then asked for it to be repeated again. And we know there's natural variations in blood pressure, and then the blood pressure was 104, so they said blood pressure fine, and actually it was a AAA, and the low blood pressure because it was a leak in AAA. Anchoring bias is when you anchor your diagnosis to the first thing you think of. So a good example is we had someone who had a cerebellar stroke, but was diagnosed by a paramedic as being drunk, then diagnosed by the first consultant who we do this primary assessment team, you see them at the front door, who said they were drunk. And it was only on the ward round in the morning when they were still slurred speech that we realised we'd missed a cerebellar stroke. Availability bias is when you make diagnosis of what's common, not what's common, but the only things you're thinking about. During the COVID pandemic, the second wave, I saw a patient, and I assumed he had COVID, and the COVID, the CRP was 290. The COVID swab came back as negative. It's like, oh, repeat the COVID swab. Repeat the COVID swab. Came back again as negative. And instead of giving antibiotics, I asked for a third. I even sent it to our other hospital because I was sure that the machine wasn't working, even though other people's swabs were coming back as positive. And he actually had leishmaniasis disease, and he had infection of the internal jugular vein. And I delayed antibiotics, which could have caused him harm. He survived and did fine in the end, but it was my fault because I was stuck in an availability bias. There's another type of bias called fixation error, and this is a typical specific type of bias when thinking. I'm just going to play this video.
When I bang my clipboard on the dash like so, I'd like you to imagine someone stepped in front of the car and execute an emergency stop, retaining full control of the vehicle. Please pull away when it is safe to do so.
That's an example of fixation bias. That's obviously a non-clinical one, but they happen in clinical environments all the time. And an example where we were sure someone had laryngospasm, but what actually happened was the oxygen had been pulled out of, the tubing had been pulled out of wall oxygen and got pushed into wall air, and we didn't even think of that. So be careful of fixation biases. Then there's problems about type 2 decision making in medicine. Type 2 decision making is when you've got time and it's slow and methodical, and you've got time to come to your diagnosis. And we when you think about treatments, always think about number needed to treat. And we often get confused by relative risk ratios and all that, but always just think about number needs to treat. We also have problems with diagnostic thinking. Sometimes we don't understand what a positive result means. And we often forget about number needed to investigate. How many investigations do we need to save a life? So think about your patients who've got a normal CT head and you're subjecting them to lumbar puncture. Actually, how many lumbar punctures do you need to do to save a life? And I just want to show you about the difficulties of diagnostic tests. So if you can put onto the chat the chances you think of this gentleman having HIV. Now, this is very important that you know this data is this is very old data. This is not new tests. This is about making a point. This is not how HIV tests are run now. So this is from when HIV tests first came out 25, 30 years ago. So please do not think this is how HIV tests are now. But this is from a famous case where a patient went to his GP, and his GP thought he was very unlikely to have HIV, about a 1% chance, but he did an HIV test. And they knew that 100% of patients with HIV tested positive, and 95% of patients tested negative, and he tested positive. Now, the actual chance of HIV, if you ask most people, they think it's like 95, 100%, but actually his chance of HIV was only 1 in 6. And that's because if you think about actual 100 patients, if you think about 100 patients, one has got HIV and they're going to test positive, and of the other 99, 5 are going to test positive for HIV, but they're going to be negative. So you're going to have 6 positive tests, of which only 1 is a true positive. So his chance of having HIV is only 1 in 6. But we are not very good as clinicians of understanding diagnostic tests, and we need to get better at it. Just want to mention civility skills are important. This is a very famous case where they looked at rude surgeons versus polite surgeons, and looked at anaesthetist performance, and they did so much better when they're working in an environment where people were nice. And then finally, I want to mention about involving patients. You know, I've done a lot trying to get the public to be prepared to speak up to us. You know, check what we're giving them, check what operations we're doing. Don't just blindly going along with your doctor, but make sure that if you're allergic to penicillin, the drug in the nurse's hand is not augmenting. So what we've been doing to strive for that safe environment, we've developed a different type of human factors course, which is very, very practical. It's a one-day course with simple take-home measures. It covers most of what we've covered here, but a lot more. Use real stories and really tries to get people to understand human factors from from the real world rather from theory. It's not done by pilots, and it looks at the 3 cornerstones of patient safety: culture, looking after staff, and traditional human factors. And it's starting to make a difference where we're working. The course has been well received, but the important thing is about on the wards, and we're starting to see impacts where we've been doing it on changing a culture, using prompt cards, changing the way people communicate, and trying to reduce error, because we know it is so difficult to make change in the NHS. At the moment, we're running so fast to stand still in an environment which is so difficult to work in. You don't need me to tell you how difficult our job's in the moment, but we can't just throw our arms in the air and say human factors aren't important. They are so important. We're not there yet, but we're closer than we were yesterday. If people want any questions or want to contact me about the course, either to be delivered, to come to a course which we do, we run courses at Brighton, Hayward Heath, Chichester and Worthing at University Hospital Sussex. If you want to come to a course, please email me, or if you want about courses in other environments, just contact me. So that's my email address and my Twitter feed if anybody wants to see some stuff on Twitter about patient safety occasionally. So thank you very much for your time coming today. I'm going to hand over to Chris, and I think I've stuck to time. So Chris, over to you. Please put your questions down on things. I've seen someone's come from Australia. That must be late at night. So please put in your questions. I'm going to read your comments whilst Chris is doing his talk, so I can get ready to answer them when Chris is finished. But put in your questions, and thank you very much.
Do you unshare now, Rob? I don't know.
Oh, sorry. Yes, I do. Apologies. Yes, and
that's cool. I'll have a go at sharing. I had a rehearsal earlier, so you never know. There we go. And if I can find, got a Norton antivirus. Okay, I'll make an assumption that I'm on screen and my slides are on screen.
You are, Chris.
Lovely, thank you very much. Thank you to that for Rob. That was very good. I enjoyed that. I wrote lots of stuff down. I'm planning to run a bit short on this so that we get a bit of chance to have some questions and conversation at the end, although questions I know will be coming in via chat, because what we don't want to do is go away and have people who've come to join these talks thinking, oh, I wish they'd talked about this or that. So if there's other stuff you want to ask about human factors, patient safety, stick them in the chat and we'll come to them at the end. Rob and I have been doing this sort of thing for a long time. The first time we've done one together. But what I'm going to do is I'm going to put a challenge out to you as the audience to say, 15 years ago, no one really knew in healthcare about human factors. But now lots of people know about it. But what we want is everybody to be doing something about it, not just to know about it. Think, oh, that was interesting. So the challenge I'm going to be putting out to you is what can I do in the role that I have that will have some human factors, patient safety impact. I wrote lots of things down, which I'm just going to chuck out before I start my talk. I like the audience interaction via chat. That's really difficult to do on a webinar. I thought that worked quite well. There was a thing about designing checklists when you've got full bandwidth. There are ways of developing checklists. There's whole piles of research that have been done on it. In healthcare, we always think, oh, I know a good way for doing this or doing that, but there is human factors, ergonomics, design characteristics to make a checklist do what it's supposed to do. I've written down malpractice. Oh, that came from earlier. Some was a television program which I was being advised to watch. Black boxes into the NHS. I wasn't sure whether that quite meant, someone wrote in the chat about actually recording, like you can have in-car video and audio recorders, and you can have black boxes in planes. We did some research a while ago, and I wore one of those body cam things that the police wear that's all encrypted, so it was and with patient consent, and you really could see and hear what was going on. And I caught loads of mistakes that I made that I hadn't realized why, but I was able to watch the video back and see what had gone wrong. But people don't feel comfortable in that environment because they think, well, if it's on camera and I've done something wrong, then I'll get blamed for it. But if you can explain what actually happened rather than our recollection, which Robert said already, our memories are fallible, then at least you're going with what actually happened rather than what we think happened or what we're making up. What else did I see? Are we losing good doctors? Yeah, it just sounded like we did lose that anaesthetist. And one of the things, particularly, I'm not sure, it's not really going to come up today, but we're talking about investigations. How we do investigations impacts enormously on people's reluctance or otherwise to speak up and tell an honest story. So we need to do this thing called a just culture and psychological safety, so that people in our teams do feel safe to speak up. And how we respond when people do point out to Rob that he's missed a fracture on an X-ray. If he gets all snappy and says, I'm the consultant, I know what I'm doing, take that patient, then they will never speak up again. Whereas even if it turns out that they're wrong on this occasion, we need to thank them for that and say, thank you very much. The reason that I think it's not an X-ray is because blah, blah, blah. Anyway, I will I got some other things, but I'll start with my bit and then we'll come back to questions and conversation at the end. So I'm Chris. I'm an anaesthetist by day job. I also teach human factors patient safety at Leicester University College of Life Sciences, and I'm the current chair of the Clinical Human Factors Group, which is the charity that Martin Bromley set up after the death of his wife Elaine. So, as Robert said, we are all fallible. It's not restricted to healthcare. I didn't know you could send tube trains the wrong way. This one was Hammersmith and City Line, but apparently it's moderately common. There's a whole backstory to that. This is a fairly recent one, just before Christmas. Forecourt pump mix-up leaves Guernsey drivers putting the wrong fuel in their tanks. This was a tanker driver. He was going to the Forest Road garage, and where he fills up the underground, under the forecourt, 50,000 gallon petrol tank. And he goes and he fills it up, but he filled it up with 50,000 gallons of diesel, and the same got the wrong one in the other tank as well. So when all the drivers turned up, they took out the petrol pump and filled their car with diesel. So humans are fallible. We're all fallible. Rob's admitted to his own. I'll admit I've got plenty under my belt as well. We all make mistakes. Healthcare is not exempt from that. Doesn't matter how hard you try to do things right. We'll all make mistakes until the day that we die or retire. So human factors is, and we heard at the very introduction, this is an International Ergonomics Association definition, and ergonomics, human factors is the same thing. Ergonomics is the American word for human factors, and human factors is the English phrase for ergonomics. They're completely interchangeable. This is a clunky definition, but it's accepted. But it does remind us it's a scientific discipline, and it's based in psychology, engineering, social anthropology, physical anthropology. And it's also a profession that applies those sciences to improving human and system performance. But that's a bit clunky. So it is about people, but importantly, it's about the way that we interact with our environment, with our equipment, and like Rob's been saying, with other people. But critically, it looks at the way those interactions can either enhance or impair our performance. And I say, Rob's looked at the interacting with other people bit, and I'm going to look more at how our environment and our equipment can affect our performance. So when human factors professionals are looking at improving safety, they can look at design. So the design of our physical workspace, the physical layout of the workspace, the temperature, the lighting, noise levels. They can look at design of equipment, so the user interface, alarm systems, that sort of thing. We can look at the systems that we've got in place in our healthcare institutions, so procedures, policies, the standard operating procedures, shift patterns, work rosters. And then we can look at the humans, the way that we select them to get the best person for the job, and the way that we train them to give them the knowledge, skills to do that job correctly. And research over the last 40, 50 years has shown consistently that the most effective way for improving safety is to improve the design of the workspace that we work in, the equipment that we work with, and the systems that we work with. And the least effective methods of improving safety is to try and train humans to be better humans. Now, as Rob said, that doesn't mean that we shouldn't do all that we can to do a good job and a safe job, recognise our limitations and put systems in place in terms of our communication skills and the other things that he was talking about. But that if we really want to make it as easy as possible for us to do our jobs well, then we need to look further back at the design and the systems, procedures and shifts that we work with. And Rob showed this Swiss cheese model, and I'm going to talk about it just briefly. It's an old model, but it still works fairly well for what we're going to talk about. If we can build these barriers, the safe environments that we work in, if we can have the best equipment that we work with, and if we can have reliable systems in place, then that means that last barrier, which is us, healthcare workers, don't have to work as hard to do a good job because lots of the hazards are taken out by having these good environments, equipment and systems. And healthcare looks more like this. We see trolleys in corridors. We know that we've got systems that don't work. I'll talk a little bit more about that in a bit. So we've got these big holes in the big pieces of cheese. Human factors. It was a human factors tool. It's old now, the Swiss cheese one, and this is a slightly more modern one. It's being introduced into healthcare a little bit. It's a hierarchy of controls. So the things that we can do that have the most effect is design at the bottom there. And then there's barriers, mitigations, and education training at the top. And I'll talk about those in a little moment. So as I said earlier, design is the most effective barrier, the most effective control measure that we can have for improving safety. So an example from my workplace, but you can see it in other industries, and you can see it a little bit in healthcare, not so much. In the left-hand side, we've got these things. We've got oxygen pipelines and nitrous oxide pipelines. You cannot plug the wrong pipeline into the wrong place because they're engineered so they won't fit. And up to about 20 years ago, and previously up to about 50 years ago, people were dying from lack of oxygen because we've got the pipes plugged into the wrong place. Can't do that. It's been engineered out now. The middle pane is the back of our anaesthetic machine. You used to be able to swap the pipelines around there as well, but they've now got non-interchangeable fittings. And on the right-hand one, which we only engineered out about 15 years ago, it used to be that you could turn on one of these knobs and deliver no oxygen at all. 15 years ago, the design was a design standard that changed, that meant if you turned up the wrong knob, the machine automatically turned up the oxygen as well. So now it's not possible because of these design changes to turn the knob and give other than oxygen when you're giving gas to a patient. And what that means is by designing out the hazard, that particular adverse event, giving someone no oxygen by accident, can't happen. And it doesn't matter how big the holes are in the other pieces of cheese, what other mistakes that we make as humans, that thing can't happen because it has been designed out. It's been engineered out. So design, We can't design out all hazards in healthcare, but the better the design of the equipment and the environment that we've got, the fewer hazards will make it through. So that generally will make the whole system safer, regardless of how the humans are behaving. There will always be some that get through. And so the next level of control in this hierarchy of controls is this thing called barriers. And in healthcare, those are the non-technical skills and the systems and procedures that we've got, some of which Rob was talking about. So up in the top left, we've got non-technical skills. So they're the things like communication, leadership, followership, readback, all those things that Rob was talking about. The other things, every member of the public, and when you go to work in healthcare, you'd think these things work. So you've got reliable systems for escalation. If something's not going right, you can report it and it will be sorted out. Your policies are readily accessible on the intranet, easy to find and easy to follow. Notes, when patients come to see you in a clinic or wherever, the notes will be available and the investigations will all be available at that time. Rosters will be timely and appropriate. So when you go to work, you'll know what you're doing that day. And by lunchtime, you'll probably know what you're doing in the afternoon. People would expect all of these things to happen as a matter of course, but we know that the systems we've got in healthcare, and there are lots of other ones, don't work as well as they should in many instances. And so what that means is we're placing too much reliance on the frontline staff who we already know are fallible, right, this left-hand piece of cheese. And so this is where the arse comes in, and we've got a coronation coming up in a couple of days. I'm going down to London. I don't know if I'll be able to see it or not. But I don't know whether the Queen can have a catchphrase, but it sort of was. Whenever she shook hands with someone, she's saying, "What do you do?" So I want you to think about what is your role, whether that be a deliverer of healthcare at the patient interface, whether it be manager, investigator, designer, and think, what can I do to try and make the environments safer? It doesn't have to be a big thing. It's just, if you can change just one thing, what's it going to be? Is there something that I can do to improve the environments, to make that slice of cheese better so that less stuff is getting to the frontline workers? Do you work somewhere where you have some influence over equipment that's being used either in your own workspace or in the hospital or GP practice as a whole? Can you help close that piece of cheese? What can you do to try and help close that piece of cheese? And then what can you do about reliable systems? Are you working in a governance role? Are you working with policies or investigation? What can you do to try and close that piece of cheese so that the frontline healthcare workers have less to do? And what that will also mean is that any adverse events that you get, there'll be fewer and they'll be less serious. So anything that you can do to close any of those pieces of cheese, as well as what Rob was saying, and there was an awful lot in that talk, it can seem a bit overwhelming when you first start at it. But if you can pick just one of those things that Rob's talking about, whether it be readback or civility, whatever, pick that one, work on that, introduce that with your colleagues. So we need to get our design right. We need to get our barriers right, our policies and our systems. And then, not going to dwell on this one for us today, but the next phase in this hierarchy of controls is mitigations. So we know that some stuff will also make it through the barriers and will start to cause harm to patients. We've got things like early warning scoring systems, so that if patients are deteriorating, a mitigation can be put in place and the outreach team can come. But an example from out there in the non-direct healthcare world, things like EpiPens. So if you're got a life-threatening allergy to peanuts, there are design things of factory lines keep peanuts separately from other places so that you can have peanut-free stuff. You get warnings put up there in some public places. If they know someone's got a life-threatening peanut allergy, they'll make announcements. But if you are out there and you start feeling that you have got this peanut allergy, the mitigation is that you can stab yourself with your EpiPen, and that starts to reduce the level of harm from that adverse event. And the final bit, which is what we're doing a bit of today, is education and training. And although I've said education and training, well, not I have said it, but it is known that education and training is the least effective method for improving safety. It's the reason for that is not because we shouldn't. It doesn't mean we shouldn't be training people. We should, but without the other things in place, it's much more likely, if you put even a well-trained worker back into a poorly designed environment with inadequate systems, they will make more mistakes and more harm will come to staff and patients than if they are working in a well-designed environment with well-designed equipment and good systems. So safe systems not well developed in healthcare, and our behaviours in healthcare really they are getting better, but they've still got a long way to go. So it's looking, and my ask to you is, what can you do? What can we help you with to help you close those holes in that Swiss cheese, to make healthcare safer for all of us, because we will be patients as well, and our patients as we stand now. So I'm going to stop there, and then we'll see what else is on the chat, if I can work out how to stop there. Oh, you are that. I thought I might have dialed out the whole show.
Charlie, do you want to share, see if there's any questions at all? Or if you do have questions, could you type them up, and then Charlie will present them to me or Chris. If you just type up any questions. Anybody who's late. Oh, sorry.
I was just going to do, someone asked about, you talked, Rob, about the person model and system model. I've just found something else, which is systems investigations. Investigation is changing in the NHS over the next 8 months we've got left now, introducing systems engineering in patient safety, SEEPs, as a model for investigation rather than root cause analysis, which looks to blame people less and help understand why they failed that day and help improve systems. So if you're working in investigation at all, you need any help with SEEPs, there's lots of sources of information out there.
So there's a question here from Eric Clement who says, given that the GMC is now saying for future hearings they will have people trained in human factors on the panel, it should be a huge step forward. Sorry, not a question, but a comment. I don't know whether you want to say anything about that.
Yeah, the GMC about 5 or 6 years ago were looking for how they could introduce human factors into their investigations, and they did quite a wide-ranging scoping exercise, and they got I think it was Lauren Morgan, who's an ergonomist, went and did their first batch of training, and they were one of the first healthcare organisations. Did the GMC get a lot of flack, but actually they were very good in taking that step forward before a lot of individual clinicians did. So it should be making a difference. Yeah, we'll always hear the bad news, but all their investigators are being trained in human factors now.
Another question. Sorry, go on, Rob.
So I think there is some historical baggage, though, from some of the cases, like the paediatric doctor Baragara, I think her name was, where I think it's put off a lot of people from reflecting and feels like it's very much an individual blame culture. Hopefully that culture is changing. I think it is, actually. I think GMC have taken on some of those criticisms appropriately, but I think the criticism in the past was appropriate, to be honest.
There's another question here that says, do you think doctors should investigate doctors, or should this be independent?
I think the investigators need to be trained investigators, and it doesn't matter whether they're subject matter experts or not, because investigation is a particular skill, but they will need subject matter experts to help them. So if Rob needs investigating because there's been a formal complaint about him and a lot more of his patient team be coming to harm, then I wouldn't. Yeah, I should have chosen me rather than Rob. If I'm being investigated, I would rather have a trained investigator who understands systems and human factors, regardless of whether they're a doctor or an anaesthetist. But I would expect them to have an anaesthetist subject matter expert who could fill them in on the technical aspects of what I was doing. But otherwise, you just get old-fashioned, well, I wouldn't have done it like that, therefore Rob's obviously a bad doctor because I would have seen that patient first, you know. So yeah, trained investigator does it if they're a doctor, added bonus, but trained investigator with a subject matter expert every time for me.
I agree.
Okay, design needs to be nationally driven. Is there an increase in this work, and are NHS procurement systems aligned to support this getting to the shop floor of our organisations?
Chris, you're better placed to answer that. Answer the next question.
Design, some of that again, I see it. Essentially, NHS supply chain is a huge complex organisation. There is human factors work going on in NHS supply chain. The first person to get through the human factors, new human factors level 2 training from the NHS actually works in the NHS supply chain. So yes, they are, but they've got millions of products on their supply chain list, so it's going to take a long time before it makes a huge difference. Yes, it's nationally driven. Manufacturers, I could talk for 2 hours on that, so I won't. It's woeful, and they come to it too late. They design their equipment, they manufacture it, and then they go, "How's this for human factors?" Instead of starting at the beginning. Anyway, that's my bias.
Okay, thank you. Next question is, what do you both think about the NHSE statement this weekend about having to balance the books above all else? Rob, do you want to take this one?
I suppose that's beyond human factors, but I suppose there's a question of people say you're overspending. Is that just underinvestment? I suppose the question is, when BP are making £4 billion worth of profits in the last 3 months, is it appropriate the NHS isn't being funded appropriately? And is it appropriate that the NHS resources have been spent on things like inappropriate PPE? That's just my politics getting to the front of the fore, because it's a vaguely political question. I wouldn't be, I have been involved in NHS management, but I do not envy any chief executive who has to combine having to balance the books versus patient safety. What human factors is, though, it can do both. If you adopt human factors, you can actually save money. I think that's important. I think the question there is outside of human factors, but I think human factors can do both. But I would not feel comfortable about putting patient safety at risk to balance books. But that's probably why I'm not going to ever be a chief executive.
Human factors isn't a substitute for adequate funding and staffing, but you've got to accept in any business, which sort of the NHS is that your first line, people always say patient safety is our top priority. Well, staying in business has got to be your top priority, because if you run out of money, then you can't run your hospital at all, and therefore no patients get treated and no staff come to work. But with the amount of money that you've got to go, can we afford to do this? So we then get into the whole business of rationing. But I think the bit where we're at is make it as easy as possible for staff to do the best job that they can with the amount of money that we've got, and to look after ourselves and the patients.
And I think that's what's important, because human factors actually doesn't cost money. If you just change a culture, you can improve outcomes and save money, and use that money for more appropriate things. The cases I've been involved in, yes, everyone talks about those awful cases where you then spend millions in litigation, but actually it's the small wins of one day less in hospital, or one less wasted blood test, that type of thing, which really does make a difference. But we both copped out of answering that question properly, Chris, because I don't want to get too political, because it's about human factors.
So someone did ask earlier, I saw it come back to readback. They were talking about how they use it in, I think it was Camp Bastion. I said, why wouldn't this be standard in the NHS? And we did some training, like the sort of thing that Rob was doing. We particularly taught readback to staff in theatres, and the staff really thought it was a good idea, and they started using it. But unfortunately, there were a number of people who hadn't been on the training. I won't say what group of staff they came from, and they came and complained, why the staff, when I say, can you go and get me the diathermy, why do they always say, I'm going to get you the diathermy? I know what I've asked them to do. And so readback, the whole team's got to buy into it and know what it's for. It's to reduce the burden on the person who's receiving it or giving information. So when Rob says, can you go and get me that full blood count? Someone goes, I'll go and get you the full blood count. Rob can just discard that now because he knows it's being done, whereas otherwise he's still sitting there 10 minutes later. I wonder if anyone's gone for it. But yeah, you do have to know. So it's whole teams need to know.
There's a really good question from Samantha Thomas about how can awareness of cultural sensitivities be better understood within human factors? For example, when some cultures don't want to speak up. I think it's really important that training is done so people, it doesn't matter which culture people are from. I know some cultures don't feel so comfortable speaking up, and the example there is Somalia. I didn't know that personally, but I think we do need to train everybody to feel comfortable. And I use the examples of when I feel uncomfortable, because it is, and people think about just challenging hierarchy. Actually, challenging friends is probably harder than challenging hierarchy at work. But we need to get that, regardless of what culture people are from, it should be a standard acceptance that in the NHS culture, we are happy to challenge hierarchy.
Some cultures are, by the nature of their culture, more deferential and therefore less likely to challenge. I was working with a guy who said, if you see me, so you've got to invite those speaking up things. So say, I'm Chris, but if you see me doing anything odd today, then do speak up. And so I'm sure you won't make any mistakes because you're the professor. I don't know, but come on, please do speak up. But you've got to invite ideas. And I said earlier, if when people do say something, you've got to acknowledge that, thank them for it, and explain why. Yes, you were right, well done, I hadn't spotted that, or actually that's a really good point, but today we're doing. So it's a teach or treat moment when someone speaks up, so that they're valued for their input.
There's another question here about, do you have any tips for implementing human factors design in one area when the solution that the team come up with might not be reflected or in line with the current trust P&P?
Oh, for design, design is really difficult, and I would say you need, if it's a complex design thing, or any sort of design thing, I say have a conversation with me separately about that. Really, I think you need co-design between an ergonomist and the users of the space or the equipment, because particularly doctors, we like to think we can design stuff. There's a whole litany of stuff that doctors have designed that really doesn't work. I'm not saying all doctors do that. There are some very good design things, but we tend to design it for the way that we work as an individual, whereas ergonomists will design it for the way that people in general tend to work. So design, very important, but very difficult. I was going to ask you, Rob, do you always get the same Chinese when you go on date night?
Of course, depending on the woman. No, that's a joke.
Don't tell your wife. You should take a card. You should have a card with it written on. They won't have to read it back to you if it's the same every bloody week.
No,
try something different, mate.
If anybody is from Hove area, Danny's on Portland Road do the most amazing takeout, but also the most amazing. You can get this buffet where they basically make whatever you want, 25 quid. It's amazing. We've got going back to Jill. Is there yes, there is a recording of it. I think Charlie's going to sort it out because I know a few people were coming in late. So if you want to see the beginning of my talks, there will be the Charlie. You can talk about how that will be done.
Yeah, we'll edit the video after this, and we'll probably circulate it to people who attended and signed up tomorrow. So we'll cut down the intro, and then we'll make sure it's circulated to everybody. We can, if you two are both happy as well, we can circulate the slides along with the recording. So if you can send the slides to me, I can get those out as well, so that if anyone's missed anything or if they want to share it with any colleagues who couldn't attend for whatever reason, they can send that around as well. And
I'll put my I didn't put it on there, but I'll put my contact email address, and I'll put the website for the Clinical Human Factors group on there. People were asking about what courses there were. So Rob's got his course. There are lots of courses, some of which are very good, some of which are rubbish, and it's very difficult to know what to pick. The Clinical Human Factors group has got some e-learning as well, which a number of trusts are using, which is on the website. Someone did ask, how do you share examples of human factors between trusts? It's very difficult. It's difficult sharing them within a trust. The human failings are the same, whatever industry you're in and whichever hospital you're in. I think it's being able to recognise those, like Rob's saying, for what they are and talk about them, and talking about the mistakes that that I make, or Rob talking about the mistakes that he makes, sort of destigmatizes them a little bit. Whereas if you're always picking on someone else, saying, oh, the reason you made that mistake is, or you shouldn't have done that. So, but sharing between hospitals is difficult. We set up a regional group where I am, but it didn't fly.
Okay, so I think we've probably got time for one or two more questions just to finish things off. There was one here I saw earlier, which I thought would be interesting.
You look for that. I was going to say to Rob, you did say this will have to be edited out of the video, so I won't actually say it again. But when you say when you're flying an airline, you don't have an overcrowded plane with passengers not putting their seatbelts on and in the aisles, unless you're on Jet 2 holidays, apparently, of course, because that was in the news recently, wasn't it? Oh, it's just like being at work, divert the plane to another airport and take them off and take them to the police station. Yeah, fine. Anyway, yes, don't mention Jet 2 holidays. Have to take that out twice in the edit. Sorry about that, Charlie.
That's all right. So there's one here saying, how do you tackle confirmation bias in a consultant with 30 plus years of experience?
Confirmation bias. You want to do that? And I think I've got a bit of a...
It's a really good question. I think the first thing is about most people don't realise they are being biased. You don't think, oh, I'm going to be doing, at the moment, I'm doing type 1 thinking and I'm biased in my type 1 thinking. What you need to do, I think, is get people to understand their biases. And I use this, if I may, I use this example of confirmation bias. And I use it with consultants and they fall for it every single time to try and, once people realise that they are human and fallible, because depending on the specialties, some consultants don't think they're human and fallible. But I give them, I'm going to give you the first 8 numbers of a number of a game, of a number rule. And I'm not going to tell you what the rule is, but you're allowed 6 more guesses. And I'm going to say correct or false, and then you're to come up with a rule. Okay? And so please just come up with those numbers. If we can do it, try and make it interactive on chat. 2, 4, 6, 8, 10, 12, 14. Next guess. If someone just types it away, or Chris, so we use you, unless you know it.
I was going to say it could be me because I didn't have a real interactive. I'm going 16.
Then, correct. Then.
Oh, I see. 18.
Correct.
20.
Then.
22.
Then
24.
Cool. What's the rule?
It was add 2 to the previous number.
No. You've fallen for a confirmation bias, Chris, because the actual rule was that the numbers just go up. But you only looked for evidence of what you were thinking of. You thought it went up in 2 and you looked for evidence of what you thought it was. You didn't challenge what you thought it wasn't. So if you'd said 2, 4, 6, 8, 10, 12, 14, 16, yeah, and then thought, right, 7,633,000, I'd have said correct. And then you said 13, I said wrong. So you were falling for a confirmation bias. And when you explain to people that's what a confirmation bias is, you only look for evidence of what you thought it was. You didn't challenge what you thought it, you know, the most likely it went up in 2s, but actually it was a trick question. And I'd just given the first few numbers went up in 2s, but then it was actually the numbers just go up. But you fell for a classic confirmation bias. And so when we can show people.
No, I didn't. No, I didn't.
So when we can show even human factors, even the lead for the clinical human factors group has fallen for the oldest trick in the book of a confirmation bias, showing that even Chris is human. When you show consultants they are human, then you say, look, you need to challenge what you think it's not, and then it can make them think. But it is hard. But it's not just consultants. Actually, consultants are very. Sometimes it's about experience. I think I fell much more for confirmation biases when I was a junior doctor. I've now got the experience to realise what I don't know. As a registrar, I thought I knew everything. Now I realise I'm a bit rubbish and I don't know that much.
Now, I'm now going to answer the question that was asked, which was how do you challenge a consultant for that? Which is one of the things that Rob had on there, which is again it's helpful if everyone knows this challenge system. And it's the cuss thing. So you go, Rob, I'm concerned that your numbers are going up at 2 every time. And he goes, yeah, 6, 8, 12. You know, I've, and then if they don't respond to that challenge, you then go, I feel uncomfortable. We still haven't considered that this might be something else. And if the consultant that was the question was talking about still doesn't respond to that, it's a graded authority challenge. So then you go, safe. It doesn't feel safe that the oxygen's still at 40 and blah blah blah. And then what you do is you go off and you find someone else if they don't respond to any of those. If people know about that cuss challenge, then when I hear someone say, I'm concerned that that's me, I'm being cussed. Okay, so I've got to go, okay, you're concerned. Let me think why it is that you think something different. It doesn't always work. I was dropping a patient off at critical care the other night to one of our registrars, Max Fax patient, and she said, oh, I'm concerned that this is another Max Fax patient. I go, okay, tell me what your concerns are. She said, I know, I just don't like Max Fax. All right. So it wasn't a cuss challenge. She used the concerned word. But yeah, I would say that's a good way to challenge someone and introduce it. It's been introduced. Fiona Kelly in Bath introduced it in their theatres, and people really like it because it's non-confrontational, but it's a controlled language so that people understand what it is. Concerned, uncomfortable, unsafe.
Brilliant. Thank you both. I think given that we've only got less than a minute left, I think we'll close the webinar there. So thank you both for your time, for your presentations, and thank you to everyone who attended as well. There was a lot going on in the chat. It was really engaging, and hopefully you've all taken something away from it.